My greetings to the fellow countrymen. My name is Ajay Chauhan and I am Professor of Medicine in a central government-run medical college and a tertiary care center called Atal Bihari Vajpayee Institute of Medical Sciences and Ram Manohar Lohia Hospital. We see that climate change is a problem which is affecting all of humanity in a very big way. Every other year we see that the number of severe heat days and extreme heat days are increasing. On the face of it, it looks quite trivial, but it has a very long-term effect on human health. The average number of cases of heat stroke which we received between 2017 to 21 over 5 years were about 755 per year. But in 2024, there was a burgeoning in the number of cases and we received as much as 52,000 cases as reported by the NCDC. In our hospital also, I've been working here as a faculty member for the past 17 years. Never had we had so many cases like we saw in the year 2024. We have 75 cases and unfortunate 27 deaths. So since this condition carries a very high degree of lethality, so it is imperative for all of us, including from layman to the paramedic to the doctor, to know what is best, how best can we resolve and treat and help the patient in need of help. So I will take you through in this series through various steps of management, right from prevention to early treatment and to late treatment. As we know, heat stroke is a triad. When the triad completes, a person is said to be suffering from heat stroke. What are the 3 points in this triad? One is core body temperature taken through rectum more than 105 degree Fahrenheit or 40.5 degrees centigrade. But we in India use Fahrenheit. So core body temperature more than 105 degree Fahrenheit, one. Second, altered sensorium. Altered sensorium, most of the time a person can be in the whole spectrum ranging from unconscious to aggressive behavior. But in case of heat stroke, to begin with, we see very aggressive behavior. Person is aggressive. And at the fag end of it, he becomes comatose. That is the time when he becomes extremely sick. These two are very easy, altered sensorium and high body temperature more than 105. But the most important thing, which is highly subjective and which doctor has to apply his brain and his judgment, is the exposure to heat stress. This is the most important thing. Now, like I said before, heat stress can exist. You don't have to see only the ambient temperature. You have to see the humidity, temperature, work condition, ventilation, air velocity, all and the type of clothes a person was wearing during those heavy effort. So all this have to factor in making a diagnosis of exertional heat stroke. There can be multiple situations in which a person can encounter heat stroke. So one classic variant of heat stroke occurs in such group of patients with comorbidities, obesity, not acclimatized. Another kind of heat stroke, which is the exertional variant, which we see in maximum number, especially in a government setting like ours. Let us play out some of these. Standing in for a prolonged period of time in a queue, doing heavy manual labor outside in atmosphere with heavy temperatures, running. The most important role, however, in managing a heat stroke is not of some peripheral big units like this. It starts right at the level of a bystander who is sitting. Early intervention can really be helpful in saving a lot of lives. In an adverse climatic condition, there is a very inclement weather. The meteorological department has said red alert or a heat wave alert. And you see the person is exerting himself or herself in outdoor surrounding or in a humidity surrounding in which there is no airflow. All of a sudden you find the person has lost his consciousness. He or she has become aggressive or lost consciousness entirely. That is one. Second, he is warm to touch. Bystander obviously cannot see the core body temperature, which is rectal, is warm and dry to touch. And third is, most importantly, history of heat. So if you find such a case, you can immediately spring into action. Take the person to the nearest area of shade, whatever you have access to. In order for an elusive best, don't compromise on the good. So if you have access to a shady tree, go under that shady tree or a building shade. Better still, you can put the person in front of a cooler. Still better, in front of an AC and make him lie down. Don't try to give water or any fluid if the person is unconscious. That can prove disastrous. So if a person is conscious, you can give him water or something to drink in upright position, never in a recumbent position. More important than that is we have to start cooling measures. Now what can be those cooling measures? We have to put ice in the axilla and groin of a person and start fanning him or her. So what should we do if we don't have ice? No problem. We should wet the axilla and the groin and start. We should pour water everywhere. We should not wait for the patient to remove his or her clothes. Early institution. quickly pour water on the person, neck down, pour him water, fan him and rush him or her to the nearest health center. And depending on the type of heat stroke, in classical we can use either evaporative or immersive cooling, but in exertional heat stroke, of which we get a far major proportion of cases, the only method suited and fast enough to bring down the temperature quickly is immersion cooling. There are various emergency coolings which can be instituted for faster cooling of a patient. Let's divide this into two categories. And the most important category is the mobile category. And this, what we see, is a static unit. The mobile unit can be comprising of, in which our setup, it does comprises of a tarpaulin, ice boxes. We have inflatable tubs also. So what we can do in periphery, if we have access to a tarpaulin, 4 people can hold one corner each of the tarpaulin, put the patient in between the tarpaulin, put lot of ice and water, make a slurry of ice water and start to oscillate the patient. This method is called as the TACO method, T-A-C-O. The most important thing is oscillation. We have to continue oscillating the patient in order for him or her to lose heat fast. So putting them, TACO has only utility if we continue to oscillate both in the lateral direction as well as side to side. So now we come to how we institute immersion cooling in our setup. So the person is, we quickly bring the person here, right adjacent to the cooling tub. In the meanwhile, one doctor puts a rectal probe, which is right there. This probe has to be inserted 15 centimeters inside the rectum of a person to record his accurate body temperature. So as soon as the person comes, we insert this probe and there is a constant monitoring of temperature of the patient, core body temperature on the monitor. And then immediately after, we put the person in ice water. It is very important to know that the head end of the patient is always above the level of ice water. So this is a tub which can be filled up in 2 minutes if we open it. We put lot of ice in it, 50 kgs of ice we put. And then transfer the patient. After putting the rectal probe, we transfer the patient in the tub as soon as we can. 1, 2, 3, lift. This is important to note that the head end is always above the water. And then we keep on stirring the water so that there is a proper contact between the patient's skin and the ice water, so as to bring down his temperature very fast. On the head, what we do is we wet the head also by this sponge, but we always make sure that we don't put head end below water, because patient in this condition more often than not are deeply comatose and suffering from altered sensorium. So that has to be clear. Sometimes patient may develop shivering, but we should not care too much about it because he's underwater. So even if shivering increases heat, there is increased dissipation through the water conductivity. So that is how we do immersion cooling. One more important thing to remember is never bring the patient's temperature down to 99 or 98.6. What we target is between 100 to 101, because even when we bring the patient out of the tub, there is a thermic after drop. So patient's temperature continue to fall even after removing from ice. So that is the recommended guideline. In case of an emergency, the choice of method of cooling is redundant. We should start early aggressive cooling. If we can lay our hands on a immersion cooling, nothing like it. But we should not wait for that ideal situation to hamper our effort in starting the treatment. It is required, if not today, tomorrow, sooner or later, or perhaps sooner than later. Every nook and corner of the country might require such a heat stroke room. Might I say that it is a very, very easy setup to do. You just have to buy 2 tubs, multi-para monitor, ice making machine. Our whole setup, besides including multi-para monitor, but not the ventilator, cost us about 18 to 20 lakh rupees. So it is not all that expensive also to set up. In this money, we have been able to establish not only the static part of the unit, but mobile part also. So having discussed the static part of heat stroke management, now let us come to dynamic part, which is ferrying a sick heat stroke patient from periphery to the hospital in an ambulance. So this is a ATLS ambulance. It already has infusion pumps, multi-para monitor, ventilator, and on the corner is a mini fridge. But we don't worry about all these big items. Even if we have a BLS ambulance, what we actually need are these items, namely the ice box, the tarpaulin, The heat stroke kit, I'll tell you the components of it later on, and if at all possible, an impervious body bag. And these are the components of heat stroke which we have inside. It contains bed sheets beside sponge packets, cold water bottles, this for mist spray. We have IV fluids which are kept cold in the refrigerator, and we have things to access IV. Besides this, it has a very important thing which is the rectal thermometer. A hospital must also have provision for some supportive services, as these are very essential in managing heat stroke. Usually these patients are very sick and moribund, so we require to have provision of ventilators in order to support them. Second very important complication of heat stroke is bleeding because of liver cell failure. So a hospital ideally has to be equipped with blood or plasma or other component bank also. Besides this, one very important complication is seizures, for which hospitals should have anti-seizure medicine, more so benzodiazepines, because valproate and barbiturates and conventional anti-seizure medicines doesn't work that well in a case of heat stroke, and benzodiazepine infusion is considered to be the best course of action.